Thank you for participating in the Safety Program for Perinatal Care II program, also known as SPPC-II, presented by the Agency for Healthcare Research and Quality, AHRQ, and the Alliance for Innovation on Maternal Health, AIM. This module will introduce you to the SPPC-II program and the Teamwork Toolkit for Obstetric Hemorrhage bundle. It will serve as the foundation to the remaining training modules that will cover a suite of useful teamwork tools and their application to managing obstetric hemorrhage in accordance with the AIM framework. Guided by the vision to achieve safe healthcare for every woman, the Alliance for Innovation on Maternal Health, or AIM, program is working towards the elimination of all preventable maternal mortality and severe morbidity across the United States. The mission of AIM is to continually improve patient safety in women's healthcare through multidisciplinary collaboration that drives culture change. To this end, AIM has created multiple patient safety bundles designed to address specific concerns within obstetric care, such as maternal hemorrhage. Working towards the improvement of overall maternal health outcomes, AIM partners with state teams and health systems to align national, state, and hospital-level quality improvement efforts and implementation of the patient safety bundles. We know you're working hard to align yourself with the AIM mission and vision statements by committing all you can to your clinical practice. You may be surprised to learn that patient safety isn't simply about the application of clinical knowledge and expertise. While these technical elements are essential, there's a second side to care that complements clinical skills, termed adaptive because they enable translation of technical competence into practice. These components include the cultural and socio-emotional elements that deeply affect the way technical elements of care are delivered. Consider for a moment how your ability to do your job is enhanced or hindered by your working relationships. Imagine how the care you provide might be or feel different when you're completely in sync with your teammates versus what it might look like if you had completely dysfunctional team dynamics. Totally different, right? Hopefully what you take away from the Simple Mind exercise is the understanding that when we have the goal to provide safe care to every woman, we have to consider both whether we are caring for her with the best clinical knowledge available and within the most effective adaptive setting. The AIM patient safety bundles that your organization is implementing satisfy the technical side. This Teamwork Toolkit aligns with those bundles to help improve the adaptive side of patient care. The SPPC-II Toolkit will do so by providing you with specific tools and strategies you can use when working with your colleagues to provide team-based care to your patients. This toolkit has been designed to connect established teamwork concepts within the context of AIM's Patient Safety Bundle for Obstetric Hemorrhage using AIM's 4Rs framework. It is comprehensive in its ability to teach language, skills, and tools you can utilize with your team daily, and presents a case scenario that demonstrates how these strategies may unfold during an obstetric hemorrhage. Not only does the toolkit provide instruction on the adaptive skills that allow you to best engage in teamwork that keeps your patient safety and quality of care at the forefront of everything, but it also discusses how to have difficult conversations and interactions with coworkers and colleagues that come from working in a stressful and busy environment. The terms and concepts on this slide will be defined and explored in detail as you complete their respective modules of the toolkit. This toolkit was built with the understanding that you are a busy working provider who can only afford minimal participatory time on online modules and in-person discussions. Therefore, each e-module will explain 1 to 2 useful teamwork tools and is expected to take no more than 12 minutes. The commitment to in-person team debriefings is minimal. This introduction e-module is the longest of the 8 online e-modules and will be completed first, as each of the remaining modules will reference the scenario presented to you within this introduction. After completion, you can either follow the suggested order Or you can complete them in random order depending on what best fits your learning needs and the direction given by your hospital AIM team lead. They can be completed in one sitting or over several weeks or months. They can also be reviewed as many times as needed. After completing the modules, you're expected to participate in at least one facilitator-led in-person debrief session. These sessions will help apply the skills and tools you learn in the e-modules to real-life scenarios. The intention is to strengthen understanding of applicability and to provide a guided forum that builds team interaction and allows for role-play practice of the tools. Check with your hospital team lead for more information about the schedule of these sessions. Your organization's champions are tasked with ensuring that everyone receives and uses the teamwork tools. You can help them with this task by completing all of the e-modules, attending the in-person debrief sessions, using the tools whenever possible, and encouraging others to do the same. The e-modules will introduce you to each tool separately, describe what it is and how it works, give you helpful tips on using it at work, and demonstrate their application in case scenarios. The Alliance for Innovation on Maternal Health, AIM, is a national data-driven maternal safety and quality improvement initiative based on proven implementation approaches to improving maternal safety and outcomes in the United States. AIM provides evidence-based frontline resources for birth facilities and provider and public health teams to adapt and implement a series of action steps or bundles on high-risk maternal conditions. Bundles are standardized, evidence-informed processes to reduce variation in response to maternal care. They are developed by multidisciplinary workgroups of experts in the field representing each of our alliance partners and specialty organizations. Readiness includes 5 areas of focus that will help facilities prepare for and prevent delays in the management of obstetric hemorrhage cases. These 5 areas include preparing a hemorrhage cart, immediate access to hemorrhage medications, establishing a response team, establishing a massive transfusion protocol, and educating team members on protocols and unit-based drills. Recognition and prevention include 3 areas of focus that should be incorporated into the care of every patient. These 3 areas include assessment of hemorrhage risk, measurement of cumulative blood loss, and active management of the 3rd stage of labor. Response includes 2 interventions that should be utilized in every hemorrhage case. These 2 interventions are an obstetric hemorrhage emergency management plan and support for patients, families, and staff who are part of a significant hemorrhage case. Reporting and systems learning include 3 focused areas of systems improvement that should be implemented by every unit that provides maternity care. These areas of systems improvement include establishing a culture of huddles and debriefs, multidisciplinary review of serious hemorrhages, monitoring outcomes and process metrics. Team structure refers to the makeup or composition of your team and is an integral part of the teamwork process. Your work would likely be impossible without the assistance and collaboration of many others, each of whom serve a critical role in providing safe, effective patient care. When your team is properly structured, it can promote teamwork by including a clear leader, involving the patient, and ensuring that all team members commit to their responsibilities. The patient care team consists of anyone with whom you work independently and dynamically to provide high-quality, safe patient care. Stop for a moment and think about who you would name as your teammates. What are their names, their job titles, their responsibilities? Why is each one an essential team member? Who did you list as part of the patient care team? You probably included on your team a primary care nurse, a charge nurse, a primary care physician, an attending physician, and residents, if you work in an academic institution. You may have also listed other providers, such as midwives, technicians, surgical assistants, and physician assistants. You may have even thought to include the blood banks. But did you think about listing a patient and the family members as part of your team? Not to worry if you didn't. It's not uncommon for many providers to leave the patient and family off their list of team members. However, it is critical to acknowledge that the patient care team is not complete without the patients and their families, who should be embraced and valued as contributing partners to patient care. Although you certainly have a core team of players who help you with your immediate responsibilities, there are others who also contribute to helping ensure the organization is operating productively and patients are served at a high standard. These include the care team. This is your core team. This team is most intimately involved in direct patient care. Coordinating team. A team comprising those work area members who are responsible for managing the operational environment that supports the core team. They are responsible for day-to-day operational management, coordination functions such as triaging emergency events and prioritizing decision-making, and resource management for care teams. Ancillary. Ancillary services provide direct, task-specific, time-limited patient care. Examples include laboratory, pathology, and radiology. Support services provide indirect, service-focused tasks which help facilitate the optimal healthcare experience for patients and their families. Examples include housekeeping and sterile processing. Administrative teams establish and communicate a vision, develop policies and expectations for staff related to teamwork, support and encourage staff during implementation and culture change, hold teams accountable for team performance. Contingency teams form for emergent or specific events and are sometimes composed of members from various teams. They are responsible for immediate, direct patient care during situations requiring more resources than are available to the care team. Examples include rapid response teams and specialist consultants. It is critical to acknowledge that a patient care team is not complete without the patient. Patients and their families should be embraced and valued as contributing partners to patient care. Throughout this course, you will learn several teamwork skills, tools, and strategies that can be adapted for use by patients and their families. Thinking about how to include patients is an important part of your implementation planning that you might find challenging. Examples of effective strategies for involving patients in their care include including the patient in bedside rounds, conducting handoffs at the patient's bedside, providing patients with tools for communicating with their care team, involving patients in key committees, actively enlisting the patient's participation. A number of organizations provide information, materials, and suggested strategies related to patient engagement, including AHRQ, the DoD, Patient Safety Program, the Joint Commission, the National Patient Safety Foundation, the U.S. Department of Health and Human Services, the Institute for Healthcare Improvement, and Consumers Advancing Patient Safety. Note, the tools on this slide will be defined and explored in detail in later modules of the toolkit. We will conclude this module with the master case scenario related to an obstetric hemorrhage case. Read through the case, which has been presented in a comic strip layout, to see the scenario that will be used and referenced throughout the entire training toolkit. At certain points in this case, you may see multiple places where clinician interactions are crucial to facilitating patient care and helping keeping them safe. These instances will be explored during the other E-modules. A 36-year-old pregnant female, Danielle Williams, who is at 38 weeks and 6 days gestational age, is referred to the labor and delivery unit from the outpatient clinic due to a blood pressure of 172 over 112, which is above her baseline. Her BMI is 34. She is gravida 7, para 6, with 6 prior vaginal deliveries. Her past medical history is complicated by chronic hypertension, for which she takes 30 milligrams of extended-release nifedipine daily, severe preeclampsia in 3 of her prior pregnancies, and postpartum hemorrhage complicating her last delivery. Otherwise, she has had an uncomplicated prenatal course with no additional complications. In labor and delivery triage, her initial blood pressure is 172 over 112, and serial blood pressures over the course of an hour reveal sustained severe range, greater of 160 over 110 systolic blood pressures, with systolic values as high as 175. Electronic fetal monitoring reveals a Category 1 tracing. The obstetrician, Dr. Sonnentag, is notified, and she places the orders to collect labs to rule out preeclampsia. The nurse, Allison, collects the ordered labs. Miss Williams is diagnosed with severe preeclampsia and is admitted to L&D for induction of labor. Allison starts a peripheral IV and treats Miss Williams' hypertension with IV labetalol for a blood pressure goal of less than 160 systolic and less than 110 diastolic. Miss Williams is given a magnesium bolus of 6 grams and started on a magnesium sulfate infusion of 2 grams per hour thereafter for seizure prophylaxis. In terms of progress of labor, her initial cervical exam is 1 centimeter, 50% effacement, and a station of -3 with the fetus in the vertex position. Miss Williams is started on oxytocin for induction of labor. Over the course of her induction, her contractions become more and more painful, and the anesthesiologist is called in to place an epidural per the patient's request. After 8 hours of oxytocin administration, Miss Williams is noted to have spontaneous rupture of membranes with clear fluid. Cervical exam by Dr. Sonnentag at that time is 6 centimeters dilated, 90% effaced, and 0 station, marking transition to active labor. 6 hours later, Miss Williams is fully dilated and starting to push. After 1.5 hours in the second stage of labor, a vigorous infant weighing 7 pounds 15 ounces is delivered vaginally. The placenta is delivered within 10 minutes of the baby's delivery. Dr. Sonnentag notes moderate bleeding in the presence of second-degree perineal laceration. The IV Pitocin rate is increased, and Dr. Sonnentag performs fundal massage to actively manage the third stage of labor. After several minutes, the uterus contracts down appropriately with slowed bleeding. Once the uterine bleeding is controlled, Dr. Sonnentag repairs the second-degree laceration in the usual fashion. The uterus is palpated one additional time following perineal laceration repair and is still noted to be firm with minimal uterine bleeding. Miss Williams is cleaned and returned to the dorsal supine position. She's given the infant for initial breastfeeding. Dr. Sonnentag and the remainder of the obstetric team, except for Allison, leave the room. The quantified blood loss at this time is 400 cc's, which is normal for a vaginal delivery. Post-delivery, Allison performs routine vital signs, fundal massage, and perineal checks every 15 minutes. 45 minutes following delivery, the patient reports to the nurse that she is feeling slightly dizzy and lightheaded. Allison repeats a set of vitals and performs postpartum fundal massage, noting a large gush of blood from Miss Williams' vagina, including several large blood clots, totaling approximately 250 cc's of blood. She calls to the charge nurse, Tanya, to notify the obstetrician that the patient is bleeding heavily. In the meantime, Allison repeats a set of vitals, showing a heart rate of 126 and blood pressure of 102/56. Soon after, Dr. Sonnentag arrives to examine the patient. Dr. Sonnentag notes active bleeding from the vagina, with an atonic uterus noted on abdominal exam. The bed is broken down once again, and Miss Williams is placed in lithotomy position after being unformed. Bimanual exam is performed, noting profound uterine atony, active bleeding, and multiple blood clots in the uterine cavity. Dr. Sonnentag asks Allison to first call for assistance. He then asks for a Foley catheter for bladder emptying, in addition to uterotonic agents and oxytocin bolus. Allison calls out to the front desk for the requested materials and supplies. Tanya brings the hemorrhage cart to the bedside, which includes the necessary supplies, the checklist, and instruction cards for medication dosing, intrauterine balloon placement, and compression stitches. She begins assisting immediately. A new peripheral IV is started, and Allison asks Dr. Sonnentag if a fluid bolus should be given. She replies affirmatively, indicating that she already has ordered blood products, and asks Allison to make the OR aware in case they need to move there for further management. While this is ongoing, Dr. Sonnentag performs bimanual uterine massage and compression, but Atney continues with vaginal bleeding. As the requested materials and supplies arrive, the decision is made to administer Hemabate at 250 micrograms. Dr. Sonnentag continues fundal and bimanual massage and requests Allison send stat labs. The L&D anesthesia team is notified and presents to the room to assist. The bleeding continues for more than 10 minutes post-Hemabate administration, but at a slower pace. Miss Williams' vitals are checked again, showing a heart rate of 135 and a blood pressure of 94/49. The laparotomy sponges, etc. are weighed and the blood in the collection drape measured for a quantitative cumulative blood loss of 1250 cc's. 1,000 milligrams of rectal misoprostol is administered along with 2 units PRBCs by the nurse per the obstetrician request. The bleeding continues to slow over the next 10 minutes, with the uterus becoming more firm with the resolution of atony. The hemoglobin test result is called back to the room at 7.1, and no additional active bleeding is noted. The patient is cleaned and returned to the supine position. Thank you for completing the introduction module. Feel free to review it as many times as needed. It is imperative that you understand AIM's 4 R's: readiness, recognition, response, and reporting, in order to best apply the upcoming tools you will learn about in the mini-modules to their structure. These 4 R's will be discussed further as they apply to each of the teamwork and communication tools highlighted within these modules. If you have any questions at this point, direct them towards your hospital AIM team leads. They are the individuals leading the in-person trainings throughout the year, and they have been extensively trained on the implementation of the toolkit. Remember to keep applying the skills and knowledge to your real-life interactions. Try to continually think about where you can use these tools and how they may be or may have been helpful in some of your clinical situations. At this point, you can begin completing the other online modules or think about your schedule so you can plan out when you'll have time to complete the remaining self-led module.